And Dr. Simenstad, will you please tell me a little more in greater details about this hip impingement and hip resurfacing?
Thank you, Dr. Jacobson. I'd be glad to. Hip impingement is a diagnosis that's relatively recently been discovered, so to speak. It's been a hidden diagnosis until this past decade. And it actually is a relatively common problem and probably existed previously but just was undiagnosed. And it's related to the abnormal shape of a hip ball or to the socket, as you showed us nicely. And it can also occur in a relatively normal ball and socket as well. But that happens usually when there's excessive movement or related to either laxity of the hip capsule or excessive range of motion in a patient, either due to their activity level or due to their laxity of their hip. Most cases, though, are related to perinatal structural deformities which occur in utero. And we think at this point in time that many of them are familial. Some can also, though, occur due to childhood developmental conditions such as slip capitofemoral epiphysis, which happens in the early years of childhood and can result in the hip growing abnormally or the ball growing abnormally related to chronic fracture or other conditions, which result in the head also becoming misshapen and thus resulting in the impinging problem as well. And as we start to understand more and more of this, we're understanding that there's a continuum of this problem. One that can be very mild and may not manifest itself until very later in life, and others with more severe incongruencies related to the head or the socket, which can result in significant problems either related to pain or arthritis at an earlier age. And so this is leading us to understand now that probably one of the single most common causes of osteoarthritis is probably related to hip impingement. So it's an important diagnosis for all of us to understand. Now, the type of patients that I usually see with this type of problem frequently present under the age of 50. And their pain is localized right into their groin, and they particularly describe the pain as being worse with exertion. They frequently have loss of motion, and particularly in hip flexion or bending of the hip, trying to bring their knee up to their chest, so to speak. And this is either due to the fact that they are very painful doing this maneuver because of torn structures, which we'll talk about, or their structural abnormalities just will not allow it because of impingement of the ball against the socket. Now, this is a very subtle diagnosis, and that's probably one of the reasons it's the hidden diagnosis for so many years. But there are significant clues that we're starting to find out that help us understand it. But just to show you how difficult the diagnosis can be, that there's frequently, on average, about 5 years from the time of symptoms to the time of diagnosis. And many times patients will see more than one doctor before the diagnosis is made. And sometimes by the time the diagnosis is made, the progression of the disease process is beyond that can be taken care of with non-arthroplastic options. So first of all, to understand this better, I think it's helpful to show what we consider the normal functional anatomy of the hip. You can see that the hip, as Dr. Kenny is going to point out for us, is essentially a round ball that fits in a socket that exactly matches the round sphere of the head. And the angle of that socket is slightly inclined so that the front half of the socket is slightly in front of the back half of the socket, which allows the hip to flex fully. There's also several other very important structures, as Dr. Jacobson described, which is the labrum in the front and back of the socket. And these are like a gasket and conceal the synovial fluid and actually help preserve the hip socket long term. When the hip is flexed, the articular surface normally, which involves almost the entire part of the head, as Dr. Kenny will describe here, goes almost all the way down to the neck. So that when the hip goes up into flexion, the entire part of the articular socket or surface goes into the socket. And the front of the neck does not really impinge because the front edge of the socket is slightly recessed in normal anatomy. Contrast that to a cam-shaped head, which is what we're going to talk about today, which is basically a head which is just too big or oval-shaped, and so it won't actually rotate into a spherical socket. or the socket can have too much overcoverage, and sometimes it can actually result in even a normal head impinging on the socket. And then, as I talked about previously, too much laxity allowing too much movement can even cause a normal hip to impinge. And all these three just different ways of causing impingement can result in the labrum becoming torn. And when the labrum's torn, it can become painful and lessen lubrication and potentially result in arthritic symptoms and because of increased friction of the hip. I've tried to show what this is basically like by taking an MRI and actually overlaying an egg shape to it, which would simulate what the head would be like. Now, if you can imagine this head going up into flexion, would first of all start to push, as Dr. Kenny will illustrate, onto the red portion of the labrum and the anterior, what we call the front of the socket. This can result in pain in and of itself, but if this happens repetitively for years, can actually result in the labrum being torn off of the articular cartilage. And once the tear has occurred, then actually cause significant pressure on the front edge of the articular surface, resulting in arthritis. So hip impingement basically presents a patient who is limiting their activities by pain, particularly flexion, and they have failed conservative measures. And they're difficult to discern whether these are simply due to impingement, because other conditions can simulate hip impingement. We need to have different ways to very clearly understand whether it's from hip impingement or from, for example, a back problem or an other type of problem related to the groin anatomy. So that we have actually several helpful tests. And the most predominant ones that we use are X-rays, which can be very helpful if shot in the right projection. In this particular case, the lateral view, looking so we can see the front edge of the neck and head and the socket, as well as the back edge, and we can compare. And at what we call MRI arthrography, which is basically an MRI after the hip has been injected with a fluid that's a special dye that you can see on MRI, which outlines the labrum nicely. And also at the same time, we inject local anesthetic in the same syringe, and that can actually be very helpful because then we can eliminate any pain for even a short period with the duration of the local anesthetic. And that will tell us that whatever pain is being relieved is coming from inside the hip capsule, and frequently is the impinging situation.